Thank you, Dr. Gonti. Our next speaker is Dr. Nathan Bennion. He's assistant professor in the Department of Radiation Oncology. He will be giving a talk on modern cervical cancer brachytherapy.
Thank you, Dr. Wall. Thank you to everybody who's been a part of organizing this. Certainly a lot of work, a lot of things I've learned. So a natural progression from head and neck cancer, cervical cancer, and brachytherapy. My favorite slide, you've seen it before maybe, but this is real. Chuck Norris, attorney at law. I represent injured people, my favorite conflict of interest. This time I did something different though. I called the phone number this week. And it gets better. The line was busy. Kid you not. It's coming out of Connecticut, I guess. Some trends in cervical cancer as we perform more screening, and you can see the United States in green down here below. But we have a lot of work to do when we are comparing it to Chuck Norris roundhouse kick fatalities. You can see a quick drop once new episodes ceased for Walker, Texas Ranger. So we have some catching up to do. The real graph was Korea, I believe. As you know, some new staging for cervical cancer. Most importantly, no horizontal spread taken into consideration for 1A, and then the 1Bs are further separated out by size, and then now finally incorporating nodal involvement. So most importantly, I'd say this is one of the exemplary treatment regimens that incorporate all aspects. It really is teamwork, like, not unlike, head and neck cancer. And so one of the most important things is planning up front, understanding, getting a complete staging and workup. And then up front, and this whole slide is just to emphasize all of the details of treatment that you can have a good idea of what will come, and leaving some room for adaptation depending on treatment response. But for external beam, to know whether you want, this is someone who you want to do 3D or IMRT. Are you going to do an SIB integrated boost for the lymph nodes? And then of course, chemotherapy coordination there. Selecting an applicator. And this is one that I feel like it's not uncommon. And if Jane is listening, the nurse that I work with closely to schedule these, it's not uncommon to say, well, at this point, if we don't have a response, this would be an interstitial implant, and depending on the response, maybe we can go to intracavitary. And so also letting our surgeons know the same and having an OR schedule so that then you're not left at the end waiting to make a schedule. And we'll talk more about how to choose those applicators. A parametrial boost, is it necessary? With some of them, depending on your technique, depending on the disease, what volume would you boost, and what dose would you take with that parametrial disease? Package time is something, or tumor treatment time, something that we know is important. How many days? That might affect how you're going to sequence your therapies. Is brachytherapy going to be interdigitated? Will you have some of your external beam portion during your chemo, or during your brachy? Will you do brachy in between your external beam portion, and how does that play? And then, like we said, the nodal boost. How many? What dose? What volume? And that depends a lot on anatomy, size of the nodes, and the location. And then, of course, follow-up. But just to point out the how many days question, now with more data coming out of Europe, we know that 8 weeks was the must, and that extending treatment time beyond that 8 weeks for every day, you could have up to a 1% increase in local recurrence risk. But now some pointing data, not definitive, but the effect of overall treatment time shortening by an additional week, so moving to 7 weeks. Their modeling shows that it's equivalent to escalating the HR, or high-risk CTV, by 5 gray, looking when considering as a dose to 90% of the volume. which they predict would improve the local control by another 1 to 2.5%, and that would depend on the initial tumor stage. So workup, I won't spend a lot of time here, but clearly physical exam, MRI, PET, these are going to tell you how to treat, especially come the time of brachytherapy, not just your external beam fields, whether it's 3D or IMRT, but clearly things like what applicators will fit if you're thinking intracavitary. Do I need to cover the vagina and how much? And then further PET disease and which nodes are we looking at? So I couldn't move, I tried to move right into brachytherapy, but I kept having a hard time, so I've got just some things for upfront external beam. You can see here, making sure we're covering obturator nodes or 2 to 3, depending on the guidelines, centimeters below vaginal involvement. I would say when I do my contours and I put on a classic 3D block, the area that I'm often most short is right here at the acetabulum. And so I often use that, importantly, contour to open that up some where needed to make sure that I've got good coverage. External beam versus IMRT. So this one, probably more just a screenshot. Here are many different contouring helps, guidelines, atlases that help us to know where are we at risk, what sort of expansions do we make on which tissues, one of which here, econtour.org gives two different cases, one by the NRG, another by the Embrace2. And so it gives you a visual, not only on normal anatomy, but how are other people contouring, which I'll show is quite different. So this is one of the contours from eContour, according to the NRG or RTOG initially, consensus guideline. And you can see back here posteriorly, we have some sparing of the rectum. They are going off of the assumption that 15 millimeters, and there are two separate studies, Lim and Jensen, that demonstrated with 15 millimeters, you're going to cover the majority. So the volume receiving 100% of your dose would be up to 98%. Whereas some others, I would say Dr. Viswanathan, contouring differently. This is the Astro contouring workshop, but she essentially says, you know, that she quotes two other studies which show that up to 50% underdosing, but that's any part of the volume receiving less than 95%, which I would agree would be an important volume. So just pointing out that this is also a point of debate, but her recommendations always to reach posterior, almost similar to a rectal cancer contour. So here's some evidence on IMRT nodal boosts, or at least where there's not evidence, some consensus, what they're doing and why when looking at the experts together. So NRG, we're going anywhere from 1.93 to 2.12 per fraction. Embrace takes it up a little bit higher outside of the pelvis, allowing for a 2.3 gray fractionation. And then noting with some papers that show, okay, we're going to have approximately 3 to 4 gray contribution from the brachytherapy. And that's taking into consideration that there's going to be 1 to 2 gray per brachytherapy dose. And it's clearly it's not adding up because it's accounting for those 1 gray per fraction. What is the EQD2 when you're getting 1 gray per treatment? But fairly agreed upon in right now for boosts to go from 55 to 65, and typically that boost being limited by organs at risk, small bowel most commonly. So what are our helpful constraints that have been well studied for the small bowel? These are duodenal constraints, mostly studied in pancreatic cancer. And so the bowel, V55, volume getting 55 gray, 1 to 15, and that's 1 for Kelly et al. And 15 for Verma et al. And then the D2CCs under the dose getting, the dose to 2 cubic centimeters, less than 55.5, or the maximum. And all of these are going to be correlated with a grade 2 bowel toxicity, less than 20%. I would say that 2 of these studies, however, are less than 10%. So this is at least what to be looking at when you're doing a nodal boost. Some normal tissue complication, you can see here when looking at doses, once we reach into that 65, the confidence intervals splay. And so we're less confident of what happens to the bowel when we're reaching doses above that. And you can see that the NTCP modeling really correlates with our constraints that have been studied elsewhere. So this is just a list of other possible, these are the constraints from the EMBRACE working group, something that you can look up under their protocol. But there are limitations to external beam radiation. Until we spread our wings, we'll never know how far we can walk. So brachytherapy is a prognostic factor, discovered in 1999, that patients who receive brachytherapy are less likely to have a local recurrence. When we look to population data, then we're going to see that external beam alone, we see lower survival rates. That's both SEER and NCDB. And then more recently, UT Southwestern, Dr. Kevin Albuquerque et al. Did a phase 2 SBRT boost. So this is our prospective randomized, prospective study to look at our best attempt with modern radiation to boost. And what we found was unacceptable toxicity. Grade 3 or more was 26%. That's very high for a grade 3. And progression-free survival was much lower than we would hope, under 50%. So I told you I was confused a little bit about cervical brachytherapy. These were implants that I don't know how they were able to get exposure. They probably had to use transrectal ultrasound guidance. But in brachytherapy, choosing an applicator. Applicators, this is an intracavitary, so no needles. This is using the areas that are already have natural cavities. So inside the vagina, the ring sits right up against the cervix, and then the tandem goes into the cervix, given that they have a patent os, and into the uterus. So it gives us that standard pear shape you can see here of the radiation dose. You can plan on a 2 centimeter extent from the tandem at the level of the ring, so from here to here, to get good coverage on tumor. So anything more than 4 centimeters, or that's asymmetric and 4 centimeters, we're going to be looking more at least these hybrid applicators. So you can see this is a tandem and ring, but now we have the ability to insert a needle, but not hold a patient for the week or use the SIAD applicator, which we'll show next. So what can we plan on these hybrid applicators delivering? So we know, so it's been studied, and we can show that instead of 2 centimeters, we can extend with parallel insertions up to 35 millimeters laterally. And if we use the oblique, which I have not used on a hybrid, then up to 4 millimeters or 40 millimeters. Generally, you don't load these just as you would like, but 10 to 20% in relation to the tandem, and then can move from there. Talking with Tanderup and Richard Potter at Estro, that they know that they use that as a starting point, but treat it then sort of like interstitial brachytherapy and just watch their hot spots. The concern here being the ureters. But use at the first fraction, usually going to put, when I've used these, I put a couple more needles in than I think I need. I'm able not to treat them, and then to use that plan from that day in subsequent fractions and know which needles I do not need to place in subsequent fractions. So I will say in the European studies that the ureteral stenosis at 5 years is 2.5%. And so that's, as far as retrospective data, that's quite acceptable. We can see that when we use the hybrid interstitial intracavitary, that they are able to increase the dose to 90% from a mean of 83 to 92 gray. And it was statistically significant based on the applicator. So favoring in these tumors that were greater than 30 cc's, also showing a 10% higher 3-year local control. And notably, no difference in dose to the OARs or reported late morbidity. So here's the, this is a Muppet applicator. Often, kind of just colloquially, that we describe interstitial as SIADs. But this is to reach the things that we cannot get to by brachytherapy alone, intercavitary alone, especially where there's extensive parametrial involvement, post-external beam, often T4 disease, and then mid to lower vaginal involvement that can't be reached by a standard tandem and ring or tandem and ovoid applicator. So next, applicator placement. This is a classic study by Akila Viswanathan, mostly pointing out, and most significantly, the symmetry of the ovoids, but demonstrating that of these two RTOG studies, 77% only, I would say, were per protocol. And that the hazard ratio for failure was double in the unacceptable group. And that was mostly shown in the symmetry of the ovoids. Also, these other 4 quality measures that they looked at, but they didn't reach statistical significance. But it's, my mentor, he would say that it's hard, at least in my words of what he taught me, that it's hard to make up for bad geometry. And so placement is essential. Getting our applicators to the tumor and further from the OARs is critical, hard to make up for in the dosimetry room. So then sim and contours, so many resources now on why and how we contour for modern brachytherapy. You can tell I've left two-dimensional kind of behind. My initial presentation had a lot of that information in it, but I think that we're all comfortable now that adding CT will decrease side effects, MR will improve local control, and that adaptive planning is something that we're looking at further. Now, how to do that is being best studied once again in Europe with that EMBRACE group. They're now not just a retro EMBRACE or EMBRACE 1, but into EMBRACE 2. And they're looking at a number of prospective endpoints, a lot of it of quality reporting, and we'll see what comes from there. But anymore, probably the most important of these is a high-risk CTV, and that's going to include the entire cervix, all tumor, and then what we call gray zones. So areas that are unequivocal, or sorry, that are difficult, indeterminate on MRI. Is there disease here or not? That should be covered in HRCTV. And then the intermediate risk will include the pre-external beam radiation, volume, so not accounting for response. Then as far as planning, we've got some new, I guess it's the newer of the consensus guidelines, but it was not new information necessarily. So here we have, again, Dr. Albuquerque putting out the compendium of dosed fractionations. These are only those that were placed for, there are other guidelines for post-op or endometrial. So this is our definitive radiation with chemoradiation, including brachytherapy. So this is a table that we'll go through briefly, just for matters of time. But you can see that there's some constricting from the ABS to the EMBRACE. So as far as aims going from our previous 80 gray now to reaching up to a maximum of 95 gray, this is Tanderup et al. And you can see that as patients have a higher dose going to 90% of the tumor, that we're having an increase in local control. You can see at 90 gray that there is still a significant benefit of local control there. For bladder dose, that was constricted after, this is also a separate and not yet in full publication, but Tanderup et al. The bladder dose, we show here that no longer is it 90 gray, but even under 70, we see a benefit, but that's really tough to meet. And so sort of a middle ground recommendation taken of 80, 90 gray if you need. And I put these together because in the case that you need to exceed in order to cover tumor, these more aggressive OAR constraints, that here you have some license to say, well, we have experience and historically we were able to go to 90 gray. And so if that's what it takes for a cure, I think that there's some safety in at least understanding where we came from and what the risk would be. The rectum as well, we can see here Mazaron et al. Takes a look. And I would add that with the 65 gray going from the 75, that we see improvement all the way to 65 gray. On the Embrace study, it's a requisite to be 70 to 75, however, and then it's just a mention of 65 if you can. And we talk here about the vaginal point. There are a lot of different vaginal constraints, and the one with the most evidence, in my opinion, would be the rectovaginal point dose. Now, this along with the 140% line, others say 200%, and then looking at the 5 millimeter depth points getting less than 85 gray. If you have all of these and you're meeting these in your plans, then I think that we could expect improved vaginal toxicities. So in the end, because my title was modern brachytherapy, I had to stick in the 80s and 90s. It was told to me before the conference that COVID was exposed to Chuck Norris, and so it will be in quarantine for the next 2 weeks.